I was the first one to do it.
Left for you? Yeah.
We can range ourselves in sequence that are lights here.
90. Alright, name the components of the conduction system. ECG's made easy, page 41, table 2. That's
What number are you on, bro?
90.
Oh my gosh. Give him a Snickers.
SA node, Bachman's bundle, AV node, bundle of his, right and left bundle branches, and the Virginia fibers. Whatever, you guys know what it is by now. Number 91. I know, autocorrect, I don't know what it was. The right coronary artery supplies what portion of the myocardium and conduction system? Page 14, table 1-3 of ECGs also. Myocardium supplied right atrium, right ventricle, inferior and surface of left ventricle, and posterior surface of left ventricle. Conductive system, SA node, AV node. Most of the right bundle branch, anterior superior fascicle of left bundle branch, part of posterior inferior fascicle of left bundle branch. SA node, AV node. I don't have that in there twice. 92. Stroke volume is determined by what three factors? Page 23 also. The degree of ventricle filling when the heart is relaxed, so the preload. The pressure against which the ventricle must pump, the afterload. And the myocardial contractile state, contracting and relaxing. What are the correct dosages of amiodarone and pulseless V-fib in a patient with VTAC with a pulse of 300 milligrams for a dead patient, 150 for that live dose. Lisinopril is an example of what group of drugs and what does it do? Couldn't find it in the pharmacology book, but I googled it. Lisinopril sounds like it's an ACE inhibitor. So then it inhibits or blocks the ACE in the lungs through the ROS system, and that way it lowers the blood pressure and the baseline filtering activity of the kidneys. Is that pretty close?
Pretty close.
Yeah.
But remember, more specifically, it's going to block angiotensin turning into angiotensin 1, turning into angiotensin 2.
Yeah. Name 3 drugs and dosages used in the treatment of angina. This is a PowerPoint of angina pectoris. Aspirin, 160 to 324, nitroglycerin, 0.4, morphine, 1 to 2 milligrams per kilogram, and fentanyl, 25 to 100 microkilograms. 96, where are beta blockers prescribed and what is the action of this group of medication? ECG is made easy, page 17. Prescribed for heart problems, blocks the beta receptors for the heart, kidneys, and lungs. Beta-1 receptors on the heart increase heart rate, contractile nerve of the heart cells. Beta-1 receptors on the kidneys release renin, which leads to ROS, and beta-2 receptors cause dilation of the bronchi. 97, what is a loop diuretic? Presentation of hypertension. Two mains, one, spironolactone for Lasix, and furosemide. Acts primarily on the ascending limb of the loop of Henle in the kidneys.
98, thiazide inhibit sodium. What does this mean? What type of patient may be on this drug? It executes the sodium to reduce volume retention to decrease the blood pressure. Patients defines in hypertensive patients and patients with edema due to CHF, liver failure, and kidney failure. How would you determine right bundle branch in the 12 lead? Select the right QRS complex. Measure QRS duration. Use V1 to differentiate between right and left. V1 displays RSR prime for right bundle branch, and then by contrast, QS pattern V1 for left bundle branch. Blood pressure determined. It's cardiac output times the peripheral vascular resistance. Unit of measurement used for pacing is milliamps. Signs and symptoms of right heart failure, tachycardia, JVD, ascites, arrhythmias, usually hypertensive, chest pain, edema in the body or lower extremities, and the gorge, liver, or spleen. Low leads represent the septic portion of the heart, will be V1 and V2. And low leads represent the lateral portion of the heart, 1, AVL, V5, and V6.
Okay, 105. What is the reciprocal change or change detected electrocardiographically in the wall of the heart opposite the site of myocardial infarction? In acute inferior wall infarction, reciprocal changes are considered a sign of more extensive myocardial damage. 106, what leads represent the inferior portion of the heart? 2, 3, and ADF. 107, where is the electrode placed on the patient's chest for V4, thick intercostal space in the midclavicular line? 108, what coronary arteries are affected with a STEMI if found in V1 through V4? Can be the left anterior descending artery and the right coronary artery. What causes artifact? Loose electrodes, broken EKG cables or wires, muscle tremors, patient movement, external chest compressions, and 60-cycle interference, which I don't know what that was. Anyone know what 60-cycle interference is?
Electricity.
When you're laying across the controls for the bed or TV remote or whatever.
Oh, okay. 110, what plane are the precordial leads in? It's horizontal plane? Would you like me to? 105 is on page 66. 106, page 56. 107, 51. 108, I didn't pay page number. Oh,
This
the
is
scandal.
Oh, I recall that. Yes.
Yeah, page 66. 110, page 48. 111, about the lecture on 111:17. Define core pulmonale and the reasons for this condition. It is pulmonary hypertension, COPD or other chronic pulmonary problems creating pulmonary hypertension. Increased pressure in the pulmonary artery leading to right ventricular hypertrophy. 112, page 131 to 132, was uncontrolled AFib. AFib with a rate greater than 100 beats per minute.
113, what are three components of Beck's triad? What does it represent? Jugular vein distension, distant heart tones, and hypotension. Represents the presence of pericardial tamponade, which is blood or other fluid in the pericardial sac. Volume 5, page 202. What are the three layers of the artery? Tunica intima is the innermost layer made of a single layer of epithelial cells. Tunica media is the elastic fiber and muscle, gives the blood vessels their strength and recoil. Tunica adventia, outermost fibrous tissue covering that gives the vessels strength to withstand the pressure generated by the heart's contractions. So as in volume 5, page 63, and volume 4, page 53. What are the names of the AV valves on the left and right sides of the heart? Left side of the heart, between left atria and left ventricle, is a mitral valve or bicuspid valve. Right side of the heart, between right atria and right ventricle, is the tricuspid valve. ECG made easy, page 8. Why does the impulse slow as it moves across the AV node in the conduction system? The delay through the AV node occurs because the fibers in the AV node are smaller than those of the atrial muscle and have few gap junctions. ECGs made easy, page 39. The anterior side of the heart is made up primarily of what part? The anterior portion of the heart lies behind the sternum and costal cartilages and consists of portions of the right atrium and left and right ventricles. ECG made easy, page 2. Name three causes of pericarditis. Causes of pericarditis are bacterial or viral infection, rheumatoid arthritis, tumors, destruction of the heart muscle, and a heart attack. ECGs, page 4. When may pacing and synchronized cardioversion be used? Pacing is used in patients with significant bradycardias that are unresponsive to atropine therapy. ECGs, page 245. And synchronized cardioversion is used in patients with unstable tachyarrhythmias. ECGs, page 125. What is the normal range for end-tidal CO2? 35 to 45, volume 3, page 182.
So 121, what type of arrhythmias may be seen in a patient who's having an inferior MI? Page 82, hyperactivity is common, resulting in Brady dysrhythmias. Number 122 is the action of an ACE inhibitor. And what type of patients will be taking this group of medication? Slows or inhibits the enzyme ACE, which is to stimulate or increase the blood pressure. Blocking this in turn lowers the blood pressure. You see in hypertension, CHF, or stroke patients. That page 123, what position would a patient be observed in for JDD? Supine at 45 degrees. 124, Levine sign is a clenched fist with the right hand over the chest, indicating heart attack or chest pain. 125, three classes of drugs that patients may be prescribed who are diagnosed with CHF. This is off the heart failure slide, diuretics, ACE inhibitors, or beta blockers. What is ascites, also off the heart failure slide? Accumulation of fluid in the abdomen. What does the vagal nerve innervate with? parasympathetic control of the heart. No page number on that one. 128, what is pitting edema and when is it seen? Swelling in the body or extremities and tissue may be tested by pushing on the swollen area to test severity, see it in right side of heart failure or kidney failure.
Alright, 129 to 134, apologize, I don't have any book numbers, so I just got them for my test. I get like an average of 67, so trust me guys, you guys are gonna get them. But no, they're also on the slide, so. Alright, what's the difference between inotropic, dronotropic, chronotropic? Inotropic is the contraction of the heart, chronotropic is the change of the heart rate, and dromotrope is the electrical system of the heart, automaticity. 130, name the signs and symptoms of dissecting AAA. There's a bunch of different kinds. We'll go with abdominal AAA. You're going to have abdominal pain, back or flank pain, hypotension, urge to defecate, pulsating masses in upper abdominal region, decreased femoral pulses, and decreased blood flow to lower extremities. Your thoracic AAA, you're going to have chest pain, anxiety, pale, tachycardic, diaphoretic, nausea, and vomiting. Number 131, what is the Currar cleft, and when would you expect to see it, and what would you do for it? So the Currar cleft you're going to see on the capnography waveform. It is a divot towards the end of the expiratory peak, and this is a sign of spontaneous respiration of your patient. This means that your patient is waking up from sedation, and you would want to resedate your patient properly. So how would you, 132, how would you prepare an epinephrine drip, and how fast would you run it? I don't know why, this is, okay, so bear with me here. So, epinephrine drip you're going to use for symptomatic bradycardia, refractory to atropines and transcutaneous pacing, and then you're going to go to your dopamine or epinephrine. Or you're going to use it for severe anaphylaxis. So we got to remember our math here. So, volume on hand times drip rate, right? So we're always going to use a 60 drip rate for our drips. And then we're going to do divided by drug on hand. So this is a handout that we all got. So we're going to start either, so 2 micrograms to 10 micrograms. Okay, so that's our drip rate. So we're going to start at 2, and then we're going to titrate up. I can't talk. So we're going to start with, so we're going to get our drug on hand first. So we're going to pull up 1 milligram of Epi 1 in 1,000 to a 250 milliliter bag. No, a lot of us don't have that, so you're going to use a Duratrol set. So this is going to give you 4 micrograms per milliliter. That's our drug on hand, okay? Then we're going to start with our, I think so, right? Yeah. So we're going to start with our,
Your volume of your 250 bag.
okay. Anyway, it's on the handout. I got this right. So anyway, so we're gonna go 2 micrograms. That's our dose. I don't know, whatever. Just look on the handout.
So that's 67.
Times 60 for our 60 drop rate. Anyway, so we're gonna go 2 micrograms times our drop rate divided by our drug on hand, which is gonna be 4 micrograms. It's gonna give us 30 drops per minute. And then, so we're going to divide that by 60, right? So we're going to get 2 drops per second. Look on your hand up. 133 defines systole and diastole. Diastole is the first phase of the cardiac cycle, the relaxation phase. Ventricle filling begins. Blood enters the ventricles through the bicuspid and tricuspid valves, and the pulmonic and aortic valves are closed. Systole is the period during which the chamber is contracting and blood is being ejected. This is the second phase of the cardiac cycle. Name the type of patients who would benefit from a pacemaker being implanted. So this is previous MI, sick sinus syndrome, high degree heart blocks, tachyarrhythmias, bradycardia. That's all. We'll answer that. Questions?
No.
So before you drop the mic,
What's the best position after JVP?
So the best position is 45 degrees.
Supine or city?
Supine.
what is it?
Supine, 45 degrees.
What is it?
I thought it was city.
Maybe city.
I was gonna say,
Everybody has DVD.
it's city,
Jack, it's-
sitting at 45.
You can't do laying or sitting at
I'm gonna look it up
45.
and show it to you.
What's the difference?
But that's what, yeah,
Your feet are up or your feet are down?
your body has to be up.
Your head has to be up.
Your head's down,
I know,
everybody has DVD.
but I'm saying supine versus sitting, this is sitting, this is supine.
What are you talking about? You're trying to lay down on your back.
At 45
At
degrees.
45 degrees,
I swear it looks at
it's literally just like your knee.
Won't that be semi-Fowler?
I can lay down with my knees up, I'm still supine.
So I'm saying the
You're in a
difference
recovery
between
position.
sitting at 45
Gary,
degrees.
is it sitting or supine? This is already-
What is that?
Thank you.
Sitting?
Sitting at 45 degrees.
So let me take this over a little bit, please.
Thank you.
Jack talked about with an inferior MI, you're susceptible to what rhythms again?
I said Brady dysrhythmias.
You're absolutely spot on. What does that mean to you? So it means it's huge to you all. What does it mean?
Probably be doing a dopamine drip.
Why?
When you bring them back from, if they have an MI, and they go into a VTAC, VFib, and they bring it back, and they have an inferior, you gotta be thinking, all right, they're gonna be super slow when they get ROSC, and I'm gonna have to deal with it.
Yeah, but let's deal with, just for right now, let's just deal with the inferior side of this. Why, how does it affect you all? If they're bradycardic, are they going to be hyper or hypotensive? Hypo. What's going on with their vascular system? It's wide open. So what drug is not going to work well with inferior MI? Nitro, as much as you would like to, is going to be really, really suspicious in terms of dumping the blood pressure that much worse. So it isn't, and let's be clear about this, because there's a dogma out there that you're gonna hear about, saying that you can't use nitro with inferior lead. Not true. You just need to be careful in terms of not dumping the blood pressure totally by having an inferior MI. Okay? That's the rest of that story. And you're just gonna get a lot. You're gonna run into that on an everyday basis, so that's all you need to know that. Joe, was that a question or comment?
No, we had about this with Dan yesterday, he explained the same thing, the people who are gonna use their nitro, we used to get them nitro, we don't know if it's inferior or not, but
Right.
we're still gonna use it.
So to that point, the rest of that story is, some will say that you don't start nitro until you have an IV in place. And my thing is, you have to look at your patient. If you have a patient with a decent blood pressure and they're raging with a chest pain, would I consider giving a nitro without an IV? Probably. May I pay a price for it in terms of dumping the blood pressure? Perhaps. So the idea in terms of putting that IV in place, along with the possibilities of having inferior MI, you have to, that's part of your critical thinking. You have to know that about your patient. Make sense? Thanks.
If you want me to teach your next math session,
Yeah,
I'll do that.
Just refer to the
Okay, what number is it?